All right, good evening, everyone. My name is Derek, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to tonight's lecture on Say Goodbye to Varicose Veins. But before we begin, I need to make a few announcements. Please take a moment at this time to silence your cell phones to avoid any interruptions. We'd also very much appreciate if you fill out those yellow evaluation forms. Those really help us in our future planning for lectures. Also, I would like to let you know that we've moved to electronic health record called EPIC. EPIC provides quicker access to patient information, which means doctors and nurses can coordinate your care better. One of the biggest benefits of EPIC is a great online portal that's really popular with patients. The portal lets you do things like view test results, message your care team, and much more. We call the portal My BCH. And you can access it from your computer or get an app on your phone. You can sign up the next time you're at BCH patient care, or you can register today using the My BCH website or smartphone apps listed on the flyer that's in with your packets. Finally, I'd like to review the format for tonight's lecture. The lecture portion will last about 45 minutes. Afterwards, we take about 15 minutes to answer general questions. And please limit your questions to general ones so the whole group can benefit from them. And on behalf of Boulder Community Health, it's my pleasure to introduce our speaker for this evening, Dr. Jie Mao. Dr. Mao completed the Junior Honors Medical Program at the University of Florida, where she obtained her medical degree. She then went on to the University of Colorado Health and Science Center, where she served on 1-year internship in general surgery, 4 years of residency in radiology, and then 1-year fellowship in vascular and interventional radiology. In 2003, Dr. Mao joined the medical staff at BCH, where she practices both interventional and diagnostic radiology. She performed more than 500 interventional radiology procedures for treating varicose veins, and Dr. Mao sees patients at the radiology department at the BCH Foothills campus. Please help me give her a warm welcome.
Thank you. Can you hear me? Yes, everybody can hear me? Okay, great. Let me know if you can't hear me. I see some familiar faces actually in the audience, so thank you for those who are coming out again to hear this presentation. It's a topic that is very close to my heart. My mom has it really bad. She was actually one of my first few patients. One of my first patients. She's doing great. So it affects lots of patients, as you might know, of various age, various walks of life. So there are many things we can offer to help. So thank you again for coming tonight. We're going to start with some pictures. The first couple pictures are probably what a lot of the patients think of when they think of varicose veins. So ropey, thumb-sized, finger-sized veins that are traveling up and down legs, various positions of legs. Comes in different severity, different amount, different location. Can affect 1 versus 2 extremities. And those are some of the examples that we commonly see that are varicose veins. What are some lesser degree of severity veins, but also abnormal? This is the next level down, if you might call that. It's called Telangiectasias. What they are is a cluster of blue veins that are not as ropey, not as running up and down, but very focalized, sometimes raised, and you can feel them if you run your fingers over this area. But in general, they present as clusters. They can also be streaks of very superficial veins that are purple, blue in discoloration. The surrounding skin is normal, but these veins are abnormal. Here are some other examples of telangiectasias. This complex is very much connected to development of those ropey varicose veins. And then there are spider veins, which are smaller, less bumpy, less clustered, and the blue and purple is even less in amount. So some of these, and very difficult to tell on these pictures, but classically, spider veins are little pink superficial veins that are really faint to see, but you can definitely see them. And again, if they are covering a large part of a leg, patients may want to get those treated. These veins in general do not cause symptoms other than cosmetic issues, so patients seek treatment for cosmetic reasons. And these veins in general don't necessarily lead to varicose veins or telangiectasias. Meaning you can definitely have these and not have designated telangiectasias or varicose veins, or any of the subsequent medical issues that can be caused by varicose veins. Okay, so forms of varicose veins we just covered. They can come in ropey, bulgy veins, spider veins, telangiectasias, and I have seen lots of patients who have no externally visible veins, but they have lots of symptoms. What we usually tell patients and primary care doctors or any referring physician or anyone with question, when they have achy legs and they just have problems with the legs that no one else has been able to figure out what, it is not a bad idea to go ahead and get an ultrasound and look, because sometimes you're surprised what you're finding. Okay, so just really briefly, epidemiology of varicose veins, it really affects majority of the population, 50% of women. That's a lot, considering how many women there are on the planet. Again, varying degree of severity, causing various different problems. And we will see with today's presentation, varicose veins, contrary to popular belief, really is not just cosmetic. It certainly can cause quite a bit of medical issues. Increases with age and body weight and body habitus, obesity and increased BMI certainly contribute, because these veins under normal circumstances are fighting against gravity to prevent blood from pooling. And if your intrinsic girth is increased from increased body habitus and body weight, it fights against what the veins are trying to do, and therefore adds to more pressure that the veins have to fight against in addition to gravity. How many times have we heard, my mom has bad veins, my sister has bad veins? Congenital can definitely be a contributing factor, whether it's collagen vascular disease or just elasticity of the tissue being lost. We definitely see that in family members. And again, not just cosmetic, and can have symptoms despite of what it looks like. Some of the terms that you might hear and some of the symptoms that you might hear that are caused by varicose veins. Most importantly, or most commonly, heaviness, achiness. My legs swell at the end of the day. They're throbbing, they're achy. I have no energy, and I have to feel like I gotta go home and put them up on the wall or dangle them upside down in order for me to feel better. I feel better in the morning after I've slept all night, but towards the end of the day, my legs are just really achy. Those are some of the really common things that I hear. Restlessness and cramps. There are many causes for restlessness, leg syndrome, and cramps, but varicose veins is one of them. Getting on to the more severe conditions, which you will see some pictures of, hyperpigmentation, the legs become discolored, the skin becomes very tight, glistening, hair start to be affected, the hair follicles in the skin, and there are less of them. The skin breaks. We make nicks and scrapes on our skin all the time, but our bodies are equipped to heal them. When you have varicose veins and lots of swelling, you don't heal them as well. So those little nicks and scrapes can become ulcers. It can become infected easily. Our ability to heal such injuries are much less. I'm going to show you some pictures of severe cases of varicose vein causing dermatitis, pigmentation, ulceration. So just want to forewarn, some of these pictures aren't pretty. Okay, lower degree of, again, you see the red pigmentation, you see tight skin, you see discolored skin and breakage of skin, flaky skin, okay? you see an open sore that is currently being packed by a wound care clinic. Another patient, when that packing is taken away, the underlying ulcer can look like that. This is of different degrees of thickness, and wound care has different ways of treating that depending on how deep the ulcer is, what kind of material they need to treat the ulcer with. Okay, now, so these are some of the really severe cases that are caused by venous hypertension or venous insufficiency or valvular incompetence, all pretty much words that say the same thing of the underlying physiology that can cause this. So we're for sure at this point not dealing with cosmetics. What exactly is the underlying physiology? In all of our legs, we have a deep system, which in this case is drawn by the deep blue, and we have a superficial venous system, in this case in the light blue. There are bridging veins called perforators between the deep and the superficial. We absolutely need our deep system. That's why it is really important, if you ever heard the word deep vein thrombosis or DVT, that it is treated as promptly as possible. We have valves in all of our veins, deep and superficial. If you have a clot in the deep system and the valve is damaged, there is no good technology available today to fix that. So if valves break in the deep system, you get pooling down at the lower extremities that cause ulceration and dermatitis that we don't have a good surgical method to treat today. Fortunately for varicose veins, by definition, it is caused by the superficial system majority of the time. And that is the gray saphenous system and the lesser saphenous system in the back of the calf. The valves in those veins break. And when they break, blood also pools down and then goes into the little tiny veins at the lower legs that normally should be draining inward. Now they're pulling downwards. And those veins become the ropey, finger-sized veins that everybody sees and considered to be varicose veins. Here's a schematic diagram of how the valves should function. Under normal circumstances, they are tented upwards and doing systole when you walk and you squeeze your calf muscles. Those valves open up and allow blood to go back up towards your heart, because again, this is a venous system, when the arterial system carries blood down from the heart. And when the muscles relax and you're not walking, they close with each other, so the blood cannot come down. Okay, the valves prevent the blood from coming down. That's our mechanism of fighting against gravity. When they are broken and there is no mechanism for them to stay closed, and they're open or they're just kind of sort of flopping in the breeze and they don't touch each other, then blood just goes up and down as they wish, and gravity always wins. So when you're on your feet and the valves aren't preventing it from coming down, blood will pool. That causes swelling, that causes exiting of those blood into the smaller venules, and then the varicose veins. So in essence, the physical appearance of varicose veins is just a manifestation of a deeper and usually more upstream valvular issue that you're having. Okay, these valves exist all along these veins. There's a video of, a live video of what this looks like. I think that might be helpful.
This animation shows how varicose veins form. Varicose veins are swollen veins that are a blue or purple color. They show through the skin, usually on the legs and feet. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. The superficial veins lie below the surface of the skin. The deep veins pass through the deep tissues of the legs. They transport blood from the legs and feet back up towards the heart. The superficial and deep veins are connected by perforator veins. Here we show the position of the deep veins, superficial veins, and perforator veins in the leg. The deep veins run between the muscles of the legs. Contractions of these muscles, when you move your legs and ankles, help to squeeze the blood back up towards your heart. Veins also have valves that prevent the blood from flowing back towards your feet. Here we show a valve and the muscles around the vein. Varicose veins are thought to develop when the valves don't close properly. Here we show a valve in a superficial leg vein. If the valves don't work properly, the blood is able to flow backwards. Blood pools in the vein, causing the vein to stretch. This is called a varicose vein. Here we show a vein that has become varicose. Here we show a varicose vein in the lower leg. Varicose veins may cause symptoms such as aching, itchiness, or swelling of the ankles. However, often they don't cause any symptoms.
Okay, does that make sense? I think that was, I think that's helpful to see that live. Let me see if I can. Okay. Okay. So, and yes, oftentimes varicose veins don't cause symptoms and they're just cosmetically there. And sometimes I do see patients who simply want to get them cosmetically treated, but at the same time, we also take a look at what is the degree of severity of the valvular incompetence in the process of working that up. Okay, I bet some of you have heard, or most of you have heard, one of these statements. And unfortunately, sometimes doctors make these statements too. So it's not cosmetic, as we've mentioned multiple times. If you have varicose veins, with or without symptoms, and you want to know what are my risk factors of developing some of these pictures that we've seen, not everyone is going to get ulceration. As a matter of fact, if you have ulceration, it doesn't even necessarily mean varicose vein is the cause of it, because there are other sources of ulceration and pigmentation. But if you have varicose veins, or you have the symptoms that we've already covered, such as the cramps, the heaviness, the swelling, the achiness, it is not a bad idea to do an ultrasound, take a look, and just see what degree of underlying valvular insufficiency, if any, that you have. Okay, what are some of the self-care measures that we can do to help ourselves if you have some of these symptoms? If you have heaviness and achiness, but you don't really have visible external varicosities, or your veins are pretty mild and your symptoms are decently mild to the point where it's not affecting your daily quality of life, I would suggest let's try some compression stocking. What if you wore medical-grade knee-height compression stockings? How does it feel by the end of the day? Guaranteed, it's going to make you feel better. Your energy level will go up because your legs aren't going to be as achy. They're not going to be as throbbing. They're not going to swell so much. So that is going to be helpful. Exercise definitely helps. Again, there's a balance. If you're on your feet all day, because you're exercising all day, that again, gravity can take its toll. But some certain healthy balance of exercise can help when you're squeezing your muscles to fight against the gravity. Okay, maintaining a healthy weight. That is in general a good idea no matter what you're talking about, varicose veins or not. You can elevate. We obviously can't live with our feet up in the air all day long. So that is something that can help us figure out, if I elevated and I wear compression stocking and I feel better, could that really mean that I have underlying valvular insufficiency? So I'm guilty of this myself, sitting crossing legs. Presumably, if you sit crossing your legs, especially sometimes we wrap our legs even twice back, with each other, it's just culturally what we do, but you are pinching on your deep system in addition to your superficial system, and it does not help your circulation, especially if you're going to sit like that all day for a prolonged period of time. So can we think about avoiding to do that? Well, we certainly can, but it doesn't mean if you sit all day with your legs crossed that you're going to develop varicose veins. If you have varicose veins and you have achy legs, it might be helpful to try to avoid doing that. Okay, and avoid long periods of standing, long periods of sitting. If you have to, some people have a standing desk and they exercise, or they actually have a treadmill under a little walking belt under their desk if their job requires them to stand all day. If you're in a long flight, how many times have we heard get up and walk around a little bit? Don't just, sit there for 10 hours. Those all help. If you're gonna get compression stocking, I think it's very important that you get 20 to 30 millimeter grade compression. If you can't tolerate 20 to 30 because that's moderate compression, you can start with 15 to 20. That to me is the minimum for you to see a difference. There's a lot of compressions out there that are called compression stockings at Walgreens or King Soopers that are 8 millimeter to 10 to 12 millimeter. Those are pretty light and not really going to make a big difference for you. So I would start at 15. Some of my patients, for example, those ulcer patients that you've seen, they have custom-made compression because they've gone beyond 40. They've gone as high as 60 to 100 millimeter, pretty darn tight in order for them to heal their ulcers. Usually when it gets to that high, it's because they've had deep system valves that are broken. There are some alternative care measures, and since we're in Boulder, I think it's a good idea to at least cover some of them. But do they work? It's very individualized. Can they harm you? In general, not. So is it harmful to try? I don't think it's harmful to try. See if it helps you, see if it makes a difference. I have patients who swear by some of these measures and others who have seen no difference. The good news is it doesn't matter what you do on this end, it does not interfere with any surgery or procedure or any other conservative management such as compression that you can do in addition to that. Okay, we have an excellent local wound care clinic here at Boulder. We're very fortunate to have that. It is covered with surgery department as well as infectious disease department, and it takes a village. It takes team effort when patients develop dermatitis, pigmentation, and ulceration. We treat the veins, but then the wound needs to be taken care of, so oftentimes we communicate quite a bit with each other on those patients, and they get the help they need. Some of the treatments that I do at BCH these days. You might have heard some of these old-fashioned ways. Saline sclerotherapy, very painful, oftentimes not done these days because they're very painful, but in some parts of the country it is still done. These are usually done for spider veins. Stripping or ligation, old-fashioned surgical way of treating varicose veins. You might have friends or family who have had that done. We now know with stripping and ligation, they come back. It's because ligation, what that means is they go at the top of that superficial vein and they just cut it. They just make an incision, find the vein, and they suture it shut. The rest of that whole long vein is still open. So what do you think it does? What our body not naturally is made to do is there's 1,000,001 other channels connected to the rest of that long vein. And the valves are still broken in that vein. So yep, you've decreased the inflow directly from the top by cutting the vein from the top, but you haven't blocked any of the other channels. So therefore, it gets blood, the cavity is still there. Gets blood back from the other connection veins, continues to go down the leg. So what happens when we see in post-surgical ligation sometimes is the veins come back fairly rapidly, fairly quickly, and then we're left with the same issues that we have to deal with. Same thing with stripping. Sometimes they have to strip segments. Sometimes we see patients who have 1-inch cuts, segments of the thigh to get rid of that gray saphenous vein, and there's segments left in between. Surgical phlebectomy is also another word for stripping. Today's treatments, we tend not to strip, we don't ligate, we do ablation procedures. Ablation these days are usually done with laser. Some places do radiofrequency ablation. I started with radiofrequency ablation many years ago, 10 years ago plus, and have gradually moved now completely to laser because of the development and the technology of laser. And we will go over how that procedure is done in a little bit. We do microfoam sclerotherapy and microphlebectomies. They're no longer 1-inch cuts. They're tiny little jabs throughout the lower extremity, anywhere that we need to get rid of large ropey varicose veins. If the veins are very big, you get rid of the inflow source, which we'll again talk about. You do some sclerotherapy, which is an injectant that covers tortuous veins that you cannot put a laser in. They still are there. If the veins were big to begin with, the cavity is still there. If the cavity is still there, increased chance of, again, coming back through alternate pathways and remain there as at least, at minimum, a cosmetic headache. Symptoms might have gotten better from laser ablation, but if the ropey vein is still there, we don't get the cosmetic benefit. And we might get recurrent issues down the road. So I tend to do microphlebectomy on those veins if that is the case. There are other treatment methods that do not require heat for ablation. Both laser and radiofrequency ablation require heat. You can call them superglue of the veins. There essentially is what it is. At this point at Boulder Community Hospital, we do not do this procedure. There are vein centers that might offer this procedure, but it is a liquid glue, literally, that you're injecting into the vein that seals the vein down without having to generate heat. I personally think that heat works very well, and liquid glue can be dangerous. It'll go where you don't want it to go because it's a liquid. So therefore, and we've seen complications with that. So therefore, at this point, I do not do this, but you will hear about this if you were to research. Okay, to me, planning for a procedure is 75% of success of any procedure. The way we plan for varicose veins is if you come to Boulder Community for an ultrasound evaluation, we want to find out the source of the varicose veins. So oftentimes, it is not the actual varicose veins that we're starting the treatment at, which might be surprising to patients. If you have a cluster of veins at your lower ankle or your mid-calf, I'm going at the thigh where there is no externally visible varicose veins. Why? Because that is where the valvular incompetence starts. And you have to shut off the floodgate, so to speak, from the source, not just locally at where the veins are. You get rid of the source, the veins will decrease, and then you subsequently visit what else do we need to do the complete work, to get the job completely done. Is that by doing sclerotherapy? Is that by doing microphlebectomy? Answer is probably yes, oftentimes. The ultrasound at Boulder Community, I do personally. We have very good sonographers that are 15, 20-year experienced sonographers. And they will tell you that when it comes to varicose veins and the complex network of veins that are under the skin, it is very difficult for them to tell where the veins are coming from. And if they have enough experience to tell me, okay, the gray saphenous vein is abnormal, they cannot tell me about the bridging veins, which are very hard, or the perforators that you saw, which are very hard to find. And oftentimes those perforators, because they're connected to the deep system, have a lot of backup pressure from the deep system, and they alone cause ulcers without any other vein being abnormal in the leg. So I do my own ultrasound because the picture's worth 1,000 words to me. Then at the time, I have a mental picture of your leg. I put that in my report as detailed as I know how to tell me 2 weeks, 2 months down the road that you come back for a procedure, I need to know exactly what I need to do. The sonographers can tell me the basics, but I think laying an eye on your leg is very important from a physician operator standpoint. We're going to show a video here in just a little bit. At the time that you do the ultrasound is when I meet you first. Then we talk about what do we find. Do you have varicose veins? Do you have venous insufficiency? What are some of the treatment options that we can do to help you out? Do your symptoms make sense to venous insufficiency? So we talk about all that. So it serves as a consultation at the same time. And then afterwards, we get the insurance authorized based on the clinical information. There are definitive criteria and set criteria that each individual insurance companies have that we need to meet at the time of our ultrasound, and at least figure out what are some of the points that your insurance requires for you to meet in order for your insurance to cover this procedure. 99% of the time, the procedure is covered based on what the ultrasound shows, based on what you're telling me from a clinical standpoint. So it's very, very unusual that we end up doing a procedure for a patient out of pocket. So once the insurance is approved, then we call you to schedule. I'm going to show you this video. And this is typical of an ultrasound that we see at the time of an evaluation. What this is showing and what we're looking for at the time of the ultrasound is, see those leaflets? This is a vein. And see those leaflets? They don't close. They're not closing. And so it doesn't matter which way you're saying, whether orange is going towards the head. In this case, orange is going towards the head, vein is going back, blue is going backwards. You can see that when you're squeezing, there's blood going forward, but when you let up, there's all this blue, meaning it's pulling down, it's going retrograde, it's going backwards. These are the things that we're looking for at the time of your ultrasound. And the severity of the, go back to this, the severity of how many seconds that color reverses is what we're counting on at the time of the ultrasound. That determines the severity of venous insufficiency, the severity of the valvular incompetence, and that in turn indicates to your insurance whether it is medically necessary or not, whether you meet medical criteria or not. And these numbers are very well published data. Yeah, there you go. Okay. Okay, so afterwards, let's just say we went through all of this step and your insurance says, yes, we're going to cover this procedure. Interventional radiology staff calls you and said, you're approved, you're gonna get a letter as well, so you will know that. Now let's schedule the procedure. So what does the procedure look like? Everything is in the interventional radiology suite. This is me with one of my technologists, and where your leg is clean, surgically scrubbed, everything is covered in surgical equipment and in the surgical room, and the procedure is performed in a sterile environment. If we're going to do microphlebectomy, we might need to give you some conscious sedation. Conscious sedation is fentanyl and Versed, which is the same medication that you get for colonoscopies. So on the day of a microphlebectomy, you get an IV and you get some IV sedation to help with the microstripping procedure. For the laser ablation and the sclerotherapy, it's local anesthetics, and everybody tolerates that extremely well. You'd be very surprised. When we do the laser ablation, we find the lowest source that we can to get the laser in. We thread the laser all the way up to the junction of the top of the vein because you want to cover that topmost valve. You deliver what's called tumescent anesthesia, which is a mixture of lidocaine with epi and saline, and you deliver it all along this leg to cover the tissue, so that when you do laser ablation, only the vein is ablated, not the tissue around the vein. And these are just tiny little needles that get into to get the medicine delivered. Then you turn on the generator, and there's set settings that we do for different veins, and you pull the laser back at certain determined interval that I tell the technologist, and you deliver energy into this vein that then subsequently basically burns the vein as you pull the laser back. So the vein wall is cauterized, and afterwards you wear compression stocking, which squeezes out the blood and heals the vein wall shut. Okay, we mentioned earlier, if you have big giant ropes, I can laser till the cows come home. I can do multiple episodes of sclerotherapy. Chances are these have a mind of their own, the cavity remains, and you cannot possibly eliminate every single connecting vein that these veins are subsequently connected to under the skin. So what do you do after you've lasered and after you've sclerosed? These guys are still there, but your symptoms are better, but you want this gone, right? That is when you do microphlebectomy. This is some of the earlier cases and some of the more extreme cases where you have lots of veins that you need to microphlebectomize. So on the day of that procedure, that's when you get the sedation. Your veins are mapped when you're in the pre-procedure prepping room. Okay, and then you're on the table. This is another patient with a few veins mapped. And again, tumescent anesthesia is delivered along this mapped out vein, and that is what is going to allow me to go ahead and actually physically remove those veins. So you will have little nicks that you'll have to heal, but afterwards it's smooth legs. These are in cases where those veins don't disappear on their own with the other treatments. Okay, so these are our goals. And let's see some outcomes. Pre and post pictures. We want the ropes to go away. First of all, we want the symptoms to be better. We want our legs to not ache at the end of the day. We want our ankles to not swell. We want us to be able to stand on our feet. We want to have more energy to do whatever it is that we want to do. The medical improvement usually are appreciated almost immediately. The cosmetic improvement takes time for your bruising to go away, for all the tumescent anesthesia that we've delivered to be reabsorbed back and to be gone from the skin and the tissue. So in the beginning, for the first couple weeks, you might not be able to appreciate a whole lot of difference because you've got other things going on. 2 months down the road, when everything is said and done, you're gonna feel great and you're gonna wanna look great, right? Same thing, we want veins to go away and we wanna feel great. Different location, different size of veins that have the same outcome. I don't know if you can see very well, but sometimes you can see the little nicks from the microphlebectomies. These are usually about a month to 2 months out. Okay, so right after the procedure, a little bit of bruising from the microphlebectomy, that will go away. And I don't know if you can appreciate the little nicks on this patient. And this is as best as we could have gotten this. This is about 3 months out for this patient. This patient's veins were so bad that she couldn't put ski equipment on because it was hurting every time she skied. And you can imagine why. So this is definitely an improvement in quality of life. Ulcer patients. So this patient's ulcer gradually healed to this small little pinpoint, and the whole discoloration got much, much better. Okay, remember this patient? Now, this patient also has this reddish hue that you see throughout the leg. In addition to the ulcer, I want you to know that that red hue is a congenital birthmark. So that's not going to go away, but this is what we're going after. The bad skin, the ulceration. Okay, this is 1 month after treatment. This is a patient who had this for 15 years. Can you imagine living with that for 15 years? No one suggested that, hey, maybe you have venous insufficiency. And by some chance, he went to our wound care clinic who said, you need to go see Dr. Mao. And we found, for sure, very severe venous insufficiency, treated him. He got hospitalized because 15 years later, there are bugs, bacteria living under that skin for a very long time. And he got a little sick after treatment, so he was in the hospital to get his antibiotics, and literally the thing was closing in front of your eyes. If you stood in his room and talked to him for half an hour, his leg looked different. It was amazing. It's amazing. These are the kind of things that I do that makes me feel very rewarding. That's not just cosmetic. Okay, spider veins and telangiectasias, usually when you have a cluster like this, there is a small 2 to 3 millimeter vein underneath this cluster that I can find by ultrasound, that I can inject sclerosants into, that will get rid of this. So that's how we treat that. It's not a laser really candidate, too small for microphlebectomy. Basically, sclerotherapy is the treatment for this. Same thing for these veins. Okay, here's an example of sclerotherapy injection for spider veins. And this is literally how it's done. Do you guys see the veins that are just kind of going away? It's a tiny little needle. It's a syringe filled with particular kind of sclerosant, different than the sclerosant that we're going to use for the telangiectasias, but that's just technical. And you try to get into these little guys and try to get them to go away. This video makes it look much easier than it actually is, because it is very hard, as you can imagine, to get into those little spider guys. But that is what we try to do with treatment of the spider veins. That is cosmetic. There are times, if you have something in between, for example, the cluster of telangiectasias and the spider vein, and you have something in between, and we go for the spider vein, it'll cover some of the larger veins because the sclerosant is going to go everywhere. It's going to cover some of the spider deeper veins that are not exactly as big as 2 to 3 millimeter, but maybe 1 to 2 millimeter at the same time. So it is a little bit of 2 for 1. Do we worry about that? Not really, because we're going to inject the spiders. It's going to go where the valvular insufficiency usually will direct it to where it needs to go, because the veins with competent valves are going to have higher pressure and are going to have a flow direction of their own. So the sclerosant goes to the path of least resistance, which in general means the abnormal veins. So it's beneficial for us. It goes away blanching at the time of the procedure, but then it comes back pretty quickly. This video didn't go on long enough to show you that, as red streaks, okay? Where it used to be a purple vein, if you inject a sclerosant in there, it's gonna become red streaks. And those red streaks can be there for sometimes up to 4 to 5 weeks before the inflammation dies away and then the vein goes away. So it's not an immediate cosmetic response. It's not that you inject and voila, I have beautiful legs. It's gonna have some irritation, some inflammation, some redness for a number of weeks, and we do have to wear some compression stocking, and then over time it gets better. And just like any cosmetic treatment, repeat therapy sometimes is needed. If you have a leg covered in spider veins, there's only a certain amount of sclerosant that we can safely inject at a time, so people might have to come back to get repeat treatments. In the process of looking up varicose veins and evaluating patients with varicose veins, our venous system in our bodies are connected, and many times we find central deep venous abnormalities, such as the gonadal veins or iliac veins in our belly and in our pelvis. There actually are the sources of the varicose veins that people would not have known unless we came in and did the ultrasound and figured out where it's coming from. Again, the whole idea is to find out the source so we can nip it in the butt, so to speak, and then we go for the peripheral stuff. So amazing how many times we find abnormalities in the deeper system that otherwise patients would not have known about. Many different ways to treat that. We're not going to go into that in this lecture, but that's something to be aware of. And that is all I have today. So thank you very much for listening, and hope it was helpful. The handout that you have, I forgot to mention, is probably slightly different from the actual slides of the talk, but the general information is similar. Yes.
So you probably wouldn't want to answer this on tape, but it sounds like if you're going to go through with a consult and it's the day of the ultrasound, it would be good to not do a lot of self-care the week before, so you have veins that are more full at the time of the ultrasound.
Well, so whether or not you do self-care, for example, compression stocking, elevation, exercise, hydration, heck, maybe diuretics, not hydration, it is not going to reverse valvular incompetence. If you have it, doesn't matter what you do, it's going to be there. It might manifest differently if you have significant swelling at the end of the day. Might not be as swollen in the beginning, at the first part of the morning. The ultrasound consultations are 8:30 in the morning. So it's usually after you've just been supine all night. So we don't need to wait till the end of the day. It really doesn't matter for us to find the abnormalities. If you don't have valvular incompetence, you don't have it. If you have it, doesn't matter what you do, it's going to show up. So good question.
I have a question for you.
Yeah.
And that is, when you were talking about crossing your legs, were you just talking about like when you're sitting in a chair like this? Or were you?
Yeah, right. So
like
I'm going
like
to,
that?
no, I'm going to sit. So
Okay.
we do this, right?
Right.
And I sometimes do
I
this.
do that.
You know, because I'm all balled up and, because I'm thinking about something hard. I mean, imagine how many points you are pinching all up and down your legs. So first of all, at the crease, okay, and then behind your knee.
Okay.
But not really crisscross applesauce.
Yeah. Is that okay?
That's fine.
Okay. Good.
Okay. If I should give up.
Are varicose veins connected to peripheral neuropathy?
That's a great question. So there are many, many causes of peripheral neuropathy. Varicose veins, to a certain degree, especially going down to the foot, going down to the ankle, can cause numbness. Is it the only source of numbness? Well, if you have peripheral neuropathy and you have bad varicose veins, I treat the varicose veins not just for the peripheral neuropathy. I treat it because of the multitude of other health issues that might come from varicose veins and valvular insufficiency. We want your circulation to be improved no matter what. And then we see what happens to the peripheral neuropathy. I have had many patients with peripheral neuropathy, and I would tell you less than half of those patients improve on their neuropathy with varicose vein treatment. So in my experience, there are most of the time other sources of neuropathy. Whether it's, now if you have diabetes and that's the cause of neuropathy, not going to get better with varicose vein treatment. If you've had previous injury that's causing nerve issues, not going to get better. So if you already know that, I wouldn't anticipate it to get any better. But if you have no previous known diagnosis and no other foreseeable source, and you have bad varicose veins, there's a chance that it might get better. Now, there are creams over the counter that I've had patients that tell me that work. They swear up and down by them. I've seen mixed responses for patients on those as well.
After these procedures are done, what is
Recovery?
post-op? Yes. Yeah.
Great. After laser ablation, usually I do laser and sclerotherapy at the same time. It is compression stocking for 5 days, and you only have to wear it when you're up, not when you're sleeping, so it's not 24/7. 5 days is minimum though. I constantly tell people there is no such thing as over-wearing your compression stockings because they are very helpful to, now, granted that they're correctly fitted. If they're too tight, they can cause pain and circulation problems, right? And that would not apply to this situation, but if they're correctly fit and they're comfortable on you, 5 days is minimum, and the more you wear, the better. So that's laser and sclero. If you're doing just sclero, it's 3 days in general of compression. Microphlebectomy, same thing. It's about 3 days. But no strenuous activity, so no hiking, biking, skiing after any of the treatments for 3 to 5 days. And regular everyday activities fine, like walking, grocery shopping, climbing stairs at your house, those are fine, but just no exercise
I've been told that if the vein is in the femoral vein, and if the puckering is in the front of the leg, that there's nothing they can do for that. Is that true? If it's that you don't work with you don't strip a femoral vein or anything like that.
So the femoral,
if that's what's puckering, what do you do?
The femoral vein is a deep vein. You cannot strip a deep vein.
Okay.
So that would be correct. If you have femoral vein that's causing problems, you cannot get rid of femoral vein. But the femoral vein is way deep in your muscle.
So it wouldn't be
That would not be
puckering.
what's externally showing.
Interesting.
So what's externally showing has to come from something. Whether it's directly connected to the femoral vein or not, we'll find out, right? Could it be just a bridging vein? There's tons of times that you have a varicose vein that is only caused by a bridging vein that by ultrasound you see it go dive directly into the deep system. Do you treat that? Absolutely. You just get rid of the bridging vein. You don't get rid of the deep vein, but you get rid of the bridging vein if that is abnormal and the source of externally visible varicose veins. So yes. So the answer is yes, you cannot get rid of femoral vein, but I don't think that's what you're seeing externally.
Hi, I had the saline solution
Yep.
done over 30 years ago, and my veins came back.
Right.
And you did it last January.
Okay?
And my legs are great now.
Okay.
I mean, I had them pretty bad. I was wondering if they'll ever come back again. Will
So
I have to?
Right, we make veins all the time. And
Right.
if you have a propensity to have broken valves to begin with, could you develop more veins that have broken valves? Yes. Are we gonna worry about it? No. We're only gonna worry about it when they develop. And it doesn't matter how many treatments you've had. Well, if the treatments you've had before got rid of what you previously had, then what you're gonna develop in the future are new and different location, new and different veins. Then we just do the same thing. We do ultrasound to find out where they're coming from and what are the treatment options available to you at that time.
Thank you.
I have a couple of questions related to compression stockings.
Okay?
How do you feel about calf sleeves that are basically compression stockings without the foot?
Yes,
You know.
they're great.
Okay.
So by compression, what I mean is usually graduated compression. There are socks that you get at REI, say for example, that are exercise compression socks. So runners, for example, have the calf sleeves on, but they have regular socks over that, and they wear shoes over that. That is fine. For people who have swollen feet, swollen ankle because of venous pooling, the graduated compression from toe to calf is helpful because otherwise you cut off right here and the foot puffs up like a balloon if you're not squeezing the foot, right? So if you don't have that problem and you just have some focalized, say, calf veins, that very well will work just fine for you. And the compression conversation we have, it's variable by everybody. So we have that at the time of the consultation. Many times patients can't tolerate the toes on the compression socks, so they get the toeless kinds. And there are plenty of times that they get the calf sleeves because they have sensitive feet, or they have bunions, or they just have feet issues that aren't going to allow them to wear tight compression. I will have to make a judgment call at the time whether that's okay or not. Are they going to be looking at more problems with that or not? There are Velcro wraps that give you the graded compression depending on how tight you Velcro. Those are patients usually with ulcers, horrible swelling, or bad arthritis, and they really can't pull on the compressions. So the compression garment industry is vast. There's tons of options out there.
So follow-up question to that is, do you recommend you wear these all the time? And even
I got them on right now.
Even at night?
And I don't have, yes, they are fantastic. As we get older, I don't have varicose veins, and yes, I did my own ultrasound and I don't have valvular insufficiency. So, but I get achy, heavy legs because I'm on my feet all day because I do surgeries all day. So, and there was a time where I have to go home and put my feet up on the wall for half an hour just to feel better. Then I started wearing compression. The energy difference is tremendous, tremendous. And if you did an ultrasound on my leg, you cannot see edema. Ultrasound's very sensitive for edema, and we oftentimes see that in patients. So why do I feel heavy? Why does anybody come in and tell me, I just got heavy, achy legs, but you got nothing that you can find, right? We have this conversation as well on patients we've done the consultation and ultrasound on, we found nothing, but yet their symptoms are there. Compression will help you with that. So if you have swelling that's heart-related, if you have swelling that's kidney-related, or even nerve-related, compression might help there too, but perhaps not as much. But again, I think the world of appropriately fitted compression garments.
Thank you.
Dr. Mao, we have a question from an online viewer, and that question is, can a person have varicose veins without any visual symptoms?
Visible visual veins. Yes, you can have valvular incompetence. You can have broken valves in the great saphenous system or the lesser saphenous system, and there are other systems that we are not even going to mention because there's tons of other different veins that can cause you clinical symptoms, but nothing externally visible. So again, it goes back to what we, I think, said earlier, is that if you're questioning whether veins could be the cause of some of the symptoms that you're having in your legs, let's do an ultrasound and find out.
Question. Could you describe the sequence of an initial evaluation with yourself? Do we see you first and then get an ultrasound?
Okay. So you check in. So let's just say you have an appointment, 8:30 in the morning, you check in, the sonographer is going to come out and greet you, bring you into the room, and get you onto the ultrasound table. I have sonographers start your scan, because what I want them to give me your sizes, okay? Now, that is if I have the time. If I don't have the time to wait for them to finish scanning you first, I'm gonna barge in right up front, and I'm just gonna take over the scanning myself, and I will be speaking numbers and having the sonographer document things for me. Sometimes even when they do the first part of the study, then I come in, I scan myself, I confirm what they're finding, find additional things, I map out my own map that I need, and let's just say we find something else, like for example, in a woman who might have pelvic congestion, then I'll exit the room and have the sonographer potentially even do additional study. It's very variable and very individual based, but usually the sonographer starts with you first, because I want to get the basic data, and then it speeds up the evaluation for me. Okay. Yes, sir.
Can you say just a word about what properly fitted means in terms of compression socks?
Properly fitted, measured meaning. So a lot of the compression companies in the back of the package have a chart that comes with calf diameter, I think lower calf and mid calf diameter. Some companies also come with length of your calf. That's what I mean. So what I don't want people to do is go on, I love Amazon, but let's just say you go on Amazon and you just bought, it says 20 to 30 millimeter mercury compression, medical grade compression, has all these great reviews, and how do you know that that's the right fit for you? Okay, unless you do your own measurement, you look at the back of the table, and you know that's the right fit. Then different companies have different makes. So a medium in this company is going to fit you differently than a medium in another company. So that's what I mean, is we need to at least do some measurement. There's a gal that I send everybody that I see at the consultation to. She's a physical therapist in town. And she does the measurements for you. And there's a particular brand that I recommend, who's the only brand that I know of so far that takes into consideration length, because I can't tell you how many times everybody, it bunches up behind my knee and it's really tight and it's really uncomfortable. Well, maybe you need a shorter one, but then how do you get a shorter one that's appropriately compressed to your size, right? So some companies take that into consideration. So Karen helps you measure, she'll order the right stuff for you, and if it doesn't fit, you return it to her, she gives you another one that's correctly fitted. And sometimes, in spite of best efforts, we get one that doesn't quite fit well. But you return it and she'll get you another one. Yes.
A couple, 3 questions ago about the compression stockings. Wasn't clear to me whether you said you're wearing them night and day or just daytime.
Just day. I wear them just day. I have patients who wear them 24/7 because it doesn't, it gets meat, crawls under my skin, and at the end of the day, I just want to take them off. But I have patients who love them and sleep with them.
All right, Dr. Mao, we're just about finishing up. We want to thank you for coming
Thank
this
you.
evening, and please give her a round of applause.
Okay, thank you.
Appreciate it. And if everyone would please fill out your evals, that would be wonderful. Really appreciate you coming.